Today, we're going to talk about the topic of hair loss, a subject that I'm very interested in because hair loss happens to affect millions of Americans, with 1 in 5 Americans experiencing some level of hair loss. Even as a millennial myself, I commonly see my own friends, both men and women, cope with issues of thinning hair and hair loss. Mostly men deal with this issue, but there are also women, and plenty of them, who also experience it. Today, we welcome Dr. Dirk Elston to the Derm Club podcast, a world-renowned dermatologist and dermatopathologist who has extensive knowledge on this topic and will discuss the etiology of hair loss with some treatment options as well. I'm going to try to keep Dr. Elston's bios short, though it will be challenging because he has played a dominant role in the field of dermatology. Currently, Dr. Elston is the chair of the dermatology department at the Medical University of South Carolina in Charleston, and currently serves as the editor of the Journal of the American Academy of Dermatology. He is a past president of the American Academy of Dermatology and the American Society of Dermatopathology, the former director of dermatopathology at Ackerman Academy in New York City, and has served on the board of directors on the International Society of Dermatopathology and the American Board of Dermatology. He has authored over 540 peer-reviewed publications and 75 textbook chapters. Dr. Elston, welcome to the Derm Club podcast.
Thank you so much.
So let's get started, Dr. Elston. I really want our audience to understand what is hair loss and why some people develop it versus other people who don't.
Well, there are different types. So there is pattern hair loss, male and female pattern alopecia. We know that very well in males. About half of males of European or African descent will bald as they get older. People pay less attention to the fact that half of females of European and African descent will also thin as they get older. Their thinning tends to be a little bit different. They retain a frontal fringe and thin centrally, whereas men tend to have temporal recession as an early part of their pattern hair loss. But the percentages are about the same, about 50% of both European and African descent. A little bit lower in Asian populations, but very prevalent in the population as a whole. We do see some people who present for that kind of hair loss, but usually it's something else going on, a scarring form of hair loss or an acute hair shed that often unmasks the already brewing pattern hair loss. For instance, this past year between COVID and the election, everyone is shedding hair. The entire nation is shedding hair this year.
Even me.
And those who already had an inherited predilection for hair thinning over time, not only is theirs more evident, but it puts them forward in time to where they would have thinned several years from now. And so their hair loss becomes much more evident, and without treatment, they have permanent and progressive thinning of the hair.
So it sounds like stress can really accelerate the hair loss.
Stress is one cause. So stress, diet, thyroid issues, and then there are inflammatory diseases that are scarring causes of hair loss. One that's rampant right now is frontal fibrosing alopecia, anterior hairline mostly of women, early loss of the eyebrows, and then a progressive marching back of the frontal hairline.
Yeah, I actually did a case report on a patient with frontal fibrosing alopecia who is just about 32 years old. And she came in very upset. She said, I'd never had hair loss in my life. And she started to show us pictures. She had thinning of her eyebrows. And it so turned out we did a biopsy and it came back positive for FFA, which I know at this time there's a lot of uncertainty about what the etiology of FFA is. It used to be thought to be a postmenopausal skin hair loss disease, but now that's changing, and as it's being seen more in premenopausal women.
Well, the majority are still postmenopausal, but we also see it in younger women and we see it in males as well. We know that it is multifactorial. It is part of the spectrum of a condition called lichen planopilaris, or LPP. LPP causes patchy hair loss in the scalp. It's one of the more common causes of scarring hair loss. And we've known for many years that it has variants to include a variant called Graham-Little-Picardy syndrome, where there is also early loss of the eyebrows, axillary, and pubic hair. FFA shares many features with Graham-Little-Picardy syndrome, but it has one important additional feature, and that is acquired progressive kinking of the hair, where the hair that was previously straight becomes thick and twisted. That's a hormonal effect. We see that in young males with early onset male pattern alopecia, where they are going to shed, the hair first becomes progressively kinky and curled as an androgen effect before it's lost. Most forms of LPP don't show that acquired progressive kinking of the hair, but frontal fibrosing alopecia does. That was an early clue that hormonal treatment was part of the necessary treatment for that condition.
So what do you typically treat a patient with frontal fibrosing alopecia with?
Well, it depends if they're male or female, their age and childbearing potential. Hormonal treatment is often not suitable or has to be used in a different way for a woman of childbearing potential, often with the birth control pill being part of the therapy. For someone who's postmenopausal, that part is not required. And a couple of agents have been used. Finasteride is an older drug that many people know for its use in male pattern hair loss. Finasteride was not as successful. It was only partially successful, but dutasteride, which is its newer cousin, marketed for prostate conditions, has been shown to be, of the hormonal treatments, the most reliably effective in the treatment of frontal fibrosing alopecia. Now, it's not used alone. It's used with topical or systemic anti-inflammatories or a combination, but it plays a very important role for that hormonal component. Fortunately, it's not that expensive because it's often not covered by insurance. They get a little bit confused when a prostate medication is being prescribed for females who don't have prostate glands. We're successful with many of them in explaining why this is necessary and providing them with all of the articles that have been published on the subject. But when the insurance simply won't cover it, it is one of the medications that's more affordable for patients on their own and helps with the hormonal component. Again, that's only part of the story. Then there's the inflammatory component, and that has to be treated separately, either topically or with systemic medication.
Do you believe the theory about using that the use of sunscreen and rubbing it on your forehead may be contributing to FFA?
Very controversial area. So I was one of the authors of the statement from the North American Hair Research Society. So ours, the American Hair Research Society, is a group of people dedicated to the research and treatment of hair disorders in North and South America. It used to be NARS, North American Hair Research. Now we're ours. We are all of the Americas, but many Europeans and Asians are also part of the society. I was one of the authors of the statement because it is a highly controversial area. And so they wanted the group to weigh in on, what is the state of knowledge currently? We know that frontal fibrosing alopecia is an epidemic. It is increasing in frequency, and it just wasn't here the same way years ago. I mean, we just didn't see it. And now not a day goes by that we don't see sometimes several patients with it in our clinics in a single day. We know that the timing correlates with when nanoparticles started to be incorporated not only in sunscreens, but also in other cosmetics. Your grandmother's cosmetics were kind of pancakey. Now they're sheer and marvelous. The problem may be that they are sheer and marvelous. And the way they accomplish that is with nanoparticles that don't penetrate through the skin, but do penetrate into the upper portions of the hair follicle. So does that cause FFA? Answer is we don't know. We don't know if there are other chemical sunscreens that can contribute. We do know that the sunscreens dramatically decrease the risk of skin cancer and that they have, very important applications. Many people who have FFA have been heavy users, not only of sunscreen, but of cosmetics and other products, hair styling products. It's premature to blame sunscreen. I certainly wouldn't have the average person stop using sunscreen because they're, very, very important in the fight against skin cancer. But for someone with FFA, I do give them specific guidance about staying out of the sun and what to do in terms of cosmetics, sunscreen choices, sun protection choices, given our current state of knowledge and research.
Very interesting. So are you currently doing any research testing sunscreens, or is that not possible?
Well, there are many groups that have looked at statistical associations and outcomes. They have also looked at the penetration of sunscreen. They've looked at the chemical interactions of sunscreens. Most of our sunscreen products are extremely safe. Some of the controversies currently surround sunscreens and their possible effects on coral reefs. We've all read that in the paper. We know that most of the problems with the coral reefs are climate change. They are, they have nothing to do with chemical, they're climate change. Mm-hmm. Can sunscreens contribute in some way to damage to coral? We don't know. There's ongoing research, and industry doesn't want to sell bad products. They don't want to produce bad products. So they're looking into it as well and want to always refine and make things better. If we find, certain things that are involved in hair loss, they certainly will respond appropriately. The problem is we simply don't have that information. So it's tantalizing that this epidemic came when various changes in industry occurred, like nanoparticles, but we don't know cause and effect, and a lot more research is necessary.
Okay, so let's just get back a little. We spoke about frontal fibrosing alopecia. Can we talk about other factors that may cause hair loss, for instance, genetic components? I often hear, I don't know Is it a wise tale when that you get your hair pattern from your mother's father? People always ask me, my mother's father was bald. Is that why I'm starting to bald? Is this a wise tale or is this true?
Well, we know it's polygenetic, so it's more. It's not as simple as that. It is inherited. So if you have balding people on either side of your family, then you are more likely to lose hair. I have patients who say, I don't understand why I'm thinning. My mother has a full head of hair. Well, how about your brothers and uncles? Well, they're all bald. Well, that gene is 50%, or the genetic inheritance is 50% of European males and females, roughly, who are destined for pattern hair loss. But it is, there are multi-genes, early onset male alopecia, pattern alopecia, which we talked about before, that has some known genetics. The same genetics in a female cause polycystic ovarian disease. So PCOS, or polycystic ovarian disease, often presents with irregular periods, sometimes trouble getting pregnant, and often androgen effects. And those androgen effects can be acne, they can be hair loss, they can be excess hair growth on parts of the body other than the scalp. Those often go along with PCOS. And, research has suggested that PCOS is very closely related in females. PCOS in females is very closely related to early onset male pattern alopecia in males. So that's one particular syndrome that accounts for one subset. But we know the inheritance is complex, but very, very common. So when I see a scarring hair loss patient, which is, that's the majority of my hair practice, is, the simple causes of hair loss, most dermatologists are very, very good at dealing with. The patients who get referred to me are patients from across this state and neighboring states where their physicians are just at their wits' end. Things either aren't making sense or they're not responding to therapy. And it's often that more than one thing is going on. They do have scarring hair loss, but they also are in that 50% that has inherited pattern hair loss. And unless you address all aspects contributing to the hair loss, the patient's not going to have an optimal outcome.
So you mentioned scarring versus non-scarring hair loss. For our audience, can you explain what the difference is?
Absolutely. So scarring hair loss is going to be permanent. Non-scarring hair loss is there is not destruction of the hair follicle itself. Now, that doesn't always imply that it's not progressive, but it is treatable. So, and it's reversible. So to get into it a little more, scarring hair loss, those are real medical emergencies because every hair you lose is gone forever. You might be a candidate for hair transplantation, but there's no way to get that dead hair back. Whereas pattern hair loss, even though your hair gets smaller and thinner, that's a process that can be reversed with medical therapy. Medical therapy in scarring hair loss is directed at stopping the scarring process to preserve the hairs you have and then make it suitable for you to go on to surgical procedures to restore the scarred areas.
What are some examples of scarring versus non-scarring now that we understand the difference?
So non-scarring alopecia, really common one that we've talked about a lot, is inherited pattern hair loss, right? That's the most common cause. The second most cause is what we've all experienced this past year with COVID, which is the telogen effluvium. So telogen effluvium, big fancy name, hairs go through cycles. They grow for about 5 years. They go into a resting phase. Then that hair is shed and a new hair grows. When your body is faced with stress, major surgery, dietary restrictions, major weight loss, it's famine time, it's crisis time. And so your body is not going to waste energy growing hairs. So it puts a lot of hairs prematurely into that resting phase. 3 to 5 months later, all those hairs are going to start coming out. And they all come out in sync. So it's normal to lose up to 100 hairs per day. You've got about 10,000 hairs on your head, and 90% of those are in the growing phase. That means 10% are in the resting phase and will turn over with daily shed. But with great stress, up to 90% can go into the resting phase. That's a lot of hairs that are all going to start coming out together 3 to 5 months later.
Which reminds me of a story of a patient who I saw who came in. She couldn't get an appointment, and she came in with a brown bag filled with her hair and begging at the front desk for her to be seen because she was so upset that all her hair had fallen out at one time suddenly. So I'm sure you've experienced similar patients as I'm
Absolutely.
discussing.
And don't throw out that bag because there's important information in that hair. If those are normal bulb hairs, so they have a little white bulb at the end, that's a shed resting hair, a telogen hair. If instead it's all pencil point fractures, that's alopecia areata, totally different condition, different treatment. So there's a lot of information in that bag of hair that the patient brings in. So the amount of shed, the type of hairs that are shed, the condition of the scalp, all of those things tell a physician what the likely cause of the hair loss is. And then often a biopsy is needed to see if there are scarring causes under the surface.
So could you tell us what the treatment option would typically be for someone who came in with telogen effluvium, especially during COVID-19, which was one of the causes?
So those hairs that are in resting phase and getting ready to grow new hairs, they're going to come out. Nothing on heaven or earth will glue them to the scalp and keep them from coming out, right? They have to come out. So that shed has to occur. Our job is to make sure that the new hairs grow in healthy. That has to do with diet, it has to do with medication, and it also has to do with, are you programmed for inherited hair thinning? So are those hairs going to come back normal, or are they going to come back thinner because that's your genetics? If that's your genetics, then we have to address that too to get them to grow in better and not progressively thin. So the hairs that are going to shed with the telogen effluvium, those are going to shed. You'll get past it. It's temporary. The key is, do you have an underlying condition that prevents them from growing back healthy and normal? And that's where we get involved as physicians.
When it comes to a different type of hair loss, a non-scarring hair loss that's very common, androgenetic alopecia, I'm assuming that you put most of your patients on minoxidil, at least in the beginning.
So it depends. Are we talking about males or females? What's their age? What are their underlying conditions? So for a male who is generally healthy, they have options. And the most commonly used options are topical minoxidil, which is over the counter, oral minoxidil, which is more effective but is prescription, and medications like finasteride and dutasteride that block the dihydrotestosterone form of male hormone that's implicated in hair loss. Because it's a very focal blockade, it's not blocking all of the male hormones, just the ones involved in hair loss. Those are different options for patients. Of course, potential for side effects. All of those have to be individualized for any given patient. But a young male patient would have, with just pattern hair loss, that's the same as androgenetic, that person would have the options of over-the-counter topical, oral minoxidil, and then do they want the hormonal blockade therapy? In a female, it's different hormones that are involved. The topical minoxidil can still work, although it's marketed in a different strength for women. Oral minoxidil can still work well in women. The hormonal therapy we use in women tends to be different from in men because it's different hormones involved. Many of the hormones come from the adrenal gland in women. So it's not just the ovaries in women, it's also adrenal, it's peripheral conversion to androgens in the fatty tissues of the body. So the hormonal background of a male and a female is different. And so that translates to different treatment.
If you see a patient, I've seen patients come in who are on minoxidil and the topical minoxidil, and after using it for about 6 months, they see great hair growth, but they're starting to get very frustrated that this has become part of their daily routine, kind of like brushing their teeth, and they are tired of it. What do you tell them at that point when they're frustrated? Like, yes, I got good results, but it's too much of a responsibility to have to put this on my head every day.
Well, it depends on the patient. Everyone's different. Some people are good candidates for hair transplantation. If they're going to have progressive thinning, they need to use medical therapy in addition to that to keep all of the hair that they had that's destined to thin, as well as the hairs that are transplanted. Topical therapy is one option, but it's messy. Patients often don't like topicals. And the oral just works better in most patients than the topical. So oral therapy becomes an option for those patients. And the question is, do they just want oral minoxidil, or do they also want hormonal blockade? Again, each one has different side effect potential. Minoxidil is a vasodilator. So if you're very athletic and it's summertime and you're sweating, you're more prone to effects of dehydration if the veins in your legs are dilated. So that has to be taken into account. The hormonal blockade, there is some risk of erectile dysfunction. That has to be weighed against the benefits of the medication. So it's an individual decision for every individual. The question is, for the patient, at what point is the over-the-counter treatment not what they want, and they need to talk to a professional, an expert, about oral options, surgical options, things that would be prescription therapy or need a physician's care.
So every patient is unique.
Every patient is unique.
What is your advice to patients who come in and ask you about a particular diet and its relationship to hair loss? I've had patients in the past come and say, oh, I'm starting this anti-inflammatory diet. I want to see if it helps me lose less hair. Do you have any thoughts on this, on diet and its relationship to hair loss?
Well, it depends what the cause of the hair loss was. Anti-inflammatory diets are helpful for inflammatory disease. They're not helpful for non-inflammatory disease. There are dietary deficiencies that make you lose hair. One that gets a lot of press is biotin, because there are inherited, like biotinidase deficiency, which presents in infancy with a host of problems, one of them being hair loss. Based on that, there are many marketed supplements that contain biotin and promise hair growth. The problem with that biotin is in those doses, it will interfere with lab testing. And there is a national warning out to people to be careful of taking biotin, because if you have a heart attack and go to the emergency room, you can test false negative for the heart attack because you were on biotin. That's a pretty serious situation, especially for older patients. The other problem with biotin is it interferes with thyroid testing, and thyroid disorders are a common cause of hair loss. So if you're on biotin, your thyroid testing's not reliable. Many of your other lab tests can give false results if you're on biotin. The bigger problem for me is the evidence that it's really doing much of anything to help those patients is pretty weak. So patients often have spent a lot of money on dietary supplements that are not helping them, whereas a good balanced diet should be part of anyone's general health maintenance. Supplements that are very costly, that contain huge amounts of biotin, have a downside and are not usually part of the treatment regimen that I would prescribe for any of the disorders we've discussed.
Do you typically avoid biotin if people come in and say, I'm taking biotin supplements? What do you think? Should I continue? Do you usually explain to them these side effects, these potential risk factors? And
well, absolutely. I mean, I share with them the national warning that, there are real risks with taking those doses of biotin. And in general, I advise that they stop them. It's most patients are wasting their money on the supplements they're purchasing for hair growth.
Are there any advancements in diagnostic and treatment options for hair loss that you're excited about? I know that there is a lot of talk about JAK inhibitors being used for hair loss. I wanted to see what your thoughts are.
Oh, well, in medicine in general and in dermatology in particular, this is a golden age of new treatment options. We have patients with brain metastases from melanoma who get completely cured with PD-1 inhibition. Things that when I entered medicine in this field, I mean, it's miracles what is happening with drug therapy for cancer patients, for patients with psoriasis and severe forms of inflammatory arthritis. And hair loss is no different. We have treatments that are dramatically effective that are new, but it has to be the right treatment for the right disorder. So you mentioned JAK inhibitors. We use them for various forms of scarring alopecia as well as alopecia areata, but they don't really play a role in pattern alopecia or etiology effluvium. So it has to be the right medication for the right condition. And that's where you need an expert who is correctly diagnosing what's going on and offering the correct treatment. I will say that many patients with hair loss, you mentioned how big a deal it is to them. And often their concerns have been minimized by people they've tried to talk to about it. And they're not minimal concerns. My friend Elise Olson did very interesting assessment of some of her patients. She treats lymphoma, cancer, and scarring forms of hair loss. When the patients were allowed to rate the severity of their condition, guess who rated their condition as more devastating? Not the cancer patients. It was the scarring hair loss patients, right? And that kind of sums it up that, a new diagnosis of psoriasis, widespread psoriasis, has an impact on a patient similar to a new diagnosis of diabetes or a new diagnosis of cancer. Scarring hair loss has an impact that's greater when patients are allowed to rate the severity of their own illness and the impact on their lives. So it's a big deal, and we want to recognize that and treat people appropriately.
Yeah, it's a very emotional condition. And I'm sure you deal with patients every day who come in very frustrated and upset. It affects their appearance, their self-confidence. So it's a really special field that I believe has a lot more research to go and to come. And I'm sure you'll be one of those contributing to the field and to the continuing advancements that are about to flourish. And I think that, there's still room for improvement and for learning in this field.
Absolutely. And the American Hair Research Society has been key in promoting that necessary research. There's also the Cicatricial Alopecia Foundation, Alopecia Areata Foundation. There are a number of groups that are coalitions of patients and their physicians who are working for advances in these disorders. And fortunately, we have some very gifted researchers across the country and around the world who are, helping us to really dramatic advances in the treatment of severe forms of hair loss, just as they are in severe cancers and other things. All of medicine is moving forward at a tremendous pace right now.
I have one last question. Given that you are a world famous dermatopathologist, do you believe that the use of our handy dandy dermatoscope in the dermatology field has led to decreased number of biopsies, given that many times what you're looking at under the dermatoscope and how it will appear under the microscope?
Yeah, well, there's no question that anything that helps you see better is going to make you a better physician when it's a visual field, right? So for years, we've used a simple magnifying glass. We've used loupes, which are like high-powered eyeglasses. And now the dermatoscope, which uses polarized light, helps us see things we couldn't see before. I wouldn't say it leads to decreased biopsy. It leads to more appropriate biopsy. We don't biopsy some things that, might on initial inspection have looked scary, but we do biopsy things that would have been missed without the dermatoscope. So, especially in the field of melanoma, it has revolutionized the field. I can't live without my dermatoscope. In alopecia, trichoscopy, which is using the dermatoscope to look at the hairs, can be very helpful. And again, it just helps you see things. Many of them you can see with your eyes or with your eyeglasses or magnifying glass. The question is always, what's needed for that patient? I need to see what you bring in your bag. I need to see your scalp. I need to see the rest of your skin. I need your medical and family history. I need to know what medications you're on. I may need a hair collection. I may need to pull out my dermatoscope, and we may need to do a biopsy and blood tests. Again, each patient's different, and it's an appropriate evaluation to get to the bottom of what's going on and what are the right steps for treatment.
Do you believe that patients can start first, if they are starting to notice hair loss for the very first time, can they start at their primary care doctor, or do you think that they should go directly to a dermatologist and potentially a hair specialist to have
it depends on who their primary care provider is. Some may be knowledgeable. Most may run screaming when they are confronted with something they really know nothing about. It's not their field. It's not anything they're knowledgeable about. The key is to get the right patient to the right provider at the right time, right? And that's true in all of medicine.
I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.